And good evening, and welcome to the most updated Keratoconus Management Guide, Part 1. My name is Dr. Bill Tullo. I am the Medical Director of OCULUS, and thank you for attending our webinar tonight. I want to also let you know if you want more information on keratoconus, the International Keratoconus Academy, or IKA. Their website is www.keratoconusacademy.com, and any additional information on keratoconus is posted on that website. It's a great source of information and education on keratoconus. Tonight, I want to welcome our presenters. Dr. Clark Chang, everybody knows Dr. Chang. Dr. Chang, here's his financial disclosures. Key one is that he is employed by Glaukos. And my disclosure is simply I am employed by Oculus. And again, thank you for attending tonight. I just want to introduce, for the people who don't know Clark Chang, it's only probably one person in the whole webinar, but Clark is the Director of Specialty Contact Lenses at the Wills Eye Hospital in Philadelphia. He's a host of the popular podcast, Chang Reaction, and with over a decade of research experience in cornea cross-linking and other advanced corneal treatments, he was selected as the top doctor of 2020 by the National Keratoconus Foundation, and also in 2021 recipient of the AOA's Luminary Award for Distinguished Practice. With no further ado, Clark, why don't we begin our webinar?
Great. Thank you, Bill, for the introduction of saying only one person may not know me. I hope that means that there's more than one person in this webinar right now. Tonight's topic, again, just really appreciate everybody coming in and joining for the next hour. I think we're gonna hopefully have a very fun and interactive, type a question into your chat box, and also educational experiences and exchanges between clinicians. And you may be thinking to yourself, you have heard Dr. Tullo speak and a lot of the great guest speakers from Oculus, and what is different and what has changed with regard to keratoconus. And the answer may surprise you. So that's kind of check off the list one by one. So I know that we are all very familiar with quoting our patients, and even in scientific exchanges in saying 1 in 2,000. I think many of us have this sense that with greater instrument ability and maybe greater clinical awareness of what keratoconus present as, and it has many different faces. That's be frank, and that's the reason why the 1 in 2,000 may really no longer hold. If we look at, I know this has been talked about, perhaps this citation of this paper, but it really is one of the few landmark paper that jolted the interest of a lot of clinicians around the world in saying, hey, after reviewing 4.4 million patient chart in Netherlands, and it's easier for them because, again, they have centralized, care, universal care, if you would, and so easier to kind of be able to review nationwide of patient charts and what kind of diagnostic codes that they were using to indicate keratoconus, and that they found that the prevalence, at least in their country, was 1 in 375, which is a lot greater, as you can see in the tagline here, 5 to 10 times more than what we used to think in terms of the 1 in every 2,000. And that's not the only, it can be sometimes, easy to kind of overlook if that was just one incidence of one publication. But if we look at the evolution of the epidemiology in keratoconus population around the world, you can, and I have a small table here that just lists some of the example, and it's certainly not inclusive. You can see that the incidence seemingly, and maybe particular in some regions, seems to have been rising ever since that first publication, or the iconic one that we quote 1 in 2,000 from, that's Kennedy and al. From 1986. And of course, if we were live in person, I ask you to wager what kind of study inclusion criteria they use in terms of qualifying patients or potential patients, because they did it in a community screening type of format in surveying the prevalence of keratoconus. At that time, they used retinoscopy. I think we've got to think that the fact that using retinoscopy will very likely underestimate the prevalence of keratoconus, right? I don't think that's controversial. I think what's more controversial is this number that we can't really let go of, and that's 1 in every 2,000. And in fact, some of the prevalence around the world, if you look at that Saudi Arabia publication from 2018, it was as high as 1 in every 26, which comes up to be almost 5%. And so global analysis, though, again, we cannot weigh on one particular population or one particular publication, I should say. So if we look at more of a meta-analysis from 2020, it's at least showing 1 in every 725, 1 in every 700 looking globally. But it's, so suffice to say, it's higher than previously thought, which is why this subject is very important. Also, it's one of the most common form of irregular cornea that we're going to encounter in clinic. But not only that, I think also very important, one more thing before we move on to the next slide, where Dr. Tullo may want to come in and chime in. But one more thing, I think it's also very important that we don't assess the impact of a condition or disease to our patients with just prevalence and incidence. I think we should also think about impact of the disease to their quality of vision and quality of life. And that I feel like we maybe are not quite as prepared to do so. What I meant by that is if you look at seasonal flu, okay, it is very common, but majority of the time, people recover without even intervention. And so it may not matter as much that its prevalence is really high, specifically in particular season, but keratoconus is a naturally degenerative disease that left unintervened will get worse and worse for majority of the patients who are, especially those who have other risk factors that we'll talk about. And therefore the impact can be permanent and potential and irreversible, and therefore should be treated differently than just looking at prevalence. And I think that's very important to kind of have in our mind, especially now that the prevalence may be higher. And Dr. Tullo, I know that you're an expert on you have read this global consensus on keratoconus and ectasia Delphi panel discussion publication and paper for multiple times. Do you have any input here that you would like to kind of open up the discussion on this publication?
Sure, Clark. I think this was really a sentinel moment with the publication of this paper. It really put a stake in the ground at some of the definitions and things that we've been relying upon up until then. As you know, everything from the CLEC study to even more modern studies using the old Amsler-Crumluck classification scheme, which really relied on keratometry as its staging requirement. So this paper was really groundbreaking in the fact that not only did it define the primary ectatic diseases as keratoconus, post-refractive surgery, ectasia, PMD, and keratoglobus, but more importantly, it made some position statements that I think are on the next slide that really are important to the basis and understanding of what keratoconus is. Number one, it definitively said that there isn't unilateral keratoconus. It just simply doesn't exist, even though the fellow eye of a patient with keratoconus may not show changes on a current technology, including tomography and other technologies. We do know that unilateral keratoconus doesn't exist. The eye that may not show changes is truly abnormal, and again, we should consider that case. We also know that the only difference between keratoglobus and pellucids and keratoconus is really the pattern and the location of the thinning. It's all a continuum of the same disease. And we differentiate keratoconus and pellucids by simply looking at things like the anterior elevation maps, looking at the thinnest point, inspecting with a slit lamp or looking at Schleimflug images and looking to see where the changes are occurring. And so it's fairly easy. If you go by the classic definition of what pellucid marginal degeneration is, it's a thinning that's one millimeter or less from the limbus inferiorly. It's down at 6 o'clock. So again, pellucids is really just inferior keratoconus. And also it highlights the fact that central pachymetry is not reliable, and we can't use handheld ultrasound pachymeters to make the diagnosis or to help in making the diagnosis. We really need a pachymetric map of the whole cornea.
Yeah, and Bill, I think that's such a good point, especially when you mention about looking at the characteristic area of thinning with pellucid. It used to be actually because most of the time practitioners aren't really expanding their if they are looking at only topography, they're not really expanding it like you can do this on Pentacam, where you could actually change the diameter of view of your axial map view to like 11, 12 millimeter. So most of the time a topography output is about 8 to 9 millimeter. And so you're not really looking into the area of thinning. And so that sort of pathognomic pattern of, that kissing dove really doesn't, really doesn't tell you whether it's a low keratoconus at around that sort of 8, 9 millimeter, or if it's a pellucid. And so I used to have to rely on my slit lamp to look at the area of thinning. In fact, a lot of times I don't even know that I pay that much attention to the axial map, which is the reason why I think it's a limitation of relying only on topography. And here, if you look at the expert's opinion in this publication, if you look at the list that they're saying, hey, you can differentiate between different ectatic diseases to keratoconus, which helps you to define keratoconus and detect keratoconus better. Most of them don't even really, out of the 4 category of instrument, only 1 is purely topography, right? Your anterior curvature map. Whereas everything else you can obtain from outside of your slit lamp, you can obtain from a tomographer such as Pentacam better. And therefore, I think it's very important to be able to expand into different clinical instruments that are more sensitive and specific for us in diagnosing our patients.
And I would agree with that, Clark. I also think it's really, it doesn't matter whether you call it pellucids or inferior keratoconus. The treatment and management, which we'll talk about next month on our next webinar, really won't vary if you have an ectasia that's 1 millimeter from the limbus versus 1.5 millimeters from the limbus. So I think what we call it and what we label it is less important than understanding exactly where the thinning is, so we can choose the best choice for our patient. So what really came of this global consensus, though, was the ability for us to have early diagnosis. When we look at the old Amsler-Crumluck classification methodology, it was pretty good at staging the moderate to severe disease, but it really fell apart on the early disease, again, because it was based on early technologies. And now that we have technologies that can pick up the condition much, much earlier in its course, we needed to develop a new system. And so the global consensus paper developing this criteria that's mandatory to diagnose keratoconus was really essential, because there really wasn't consensus in the literature up until then. And what it said is you need to have abnormal posterior elevation, you need to have abnormal corneal distribution or pachymetric progression as it's defined on a Pentacam, and non-inflammatory corneal thinning. And that's what you need for frank keratoconus. But for diagnosing subclinical keratoconus, or what formerly was called forme-fruste keratoconus, again, we need to have an abnormality in the posterior or back elevation. We know that most keratoconus begins on the back of the cornea, proceeds to the front eventually. And the most widely diagnostic tools that can do this is tomography, whether it's Schleimflug or OCT tomography. It's really the best current tools necessary to diagnose this condition in its early stages.
And Bill, I may be the only crazy person who differentiates between forme-fruste keratoconus and subclinical keratoconus. But that point aside, just again because we don't need to. I don't think we need to argue about the the basics and the theoretics of what makes one forme-fruste versus subclinical. But I want to pay attention though to that top area where the mandatory criteria, according to a group of experts, includes that posterior elevation and thickness distribution, not a single point of corneal thickness, and that there's no other overlying reason, or I should say underlying reason, for corneal thinning to occur, because there's such thing as a sort of secondary thinning disorder that are not your primary ectatic group, which is listed in this paper. But the reason I want to mention that again is, if you just look at that, then you realize that diagnosing even by topography, which you're going to talk about later, is Again, the sensitivity and specificity is at a much later stage of keratoconus, meaning when the anterior surface is not affected, you're not going to be able to pick up those mild subclinical keratoconus. That is not to say that you cannot diagnose keratoconus, which is a question that I get all the time is, are you saying that I'm not able to pick up keratoconus patients at all with topography, because that's what I have in clinic? And that isn't what we're saying. What we're saying is if your goal is to pick up early, at the earliest point, because now there can potentially be interventions that we'll discuss next time in the part 2 webinar, then topography becomes less useful of an instrument to try to preserve vision or detect patient as early as possible. But we're not saying that you cannot use topography to diagnose keratoconus. So I do want to differentiate there, make a distinction there.
Right, but the big point is that now that there is intervention that can stop the progression of the disease, finding it as early as possible has become paramount of importance.
Absolutely. And hopefully that, we'll be able to discuss that with everyone online today, next time in our part 2 webinar. So then you may be questioning, all right, so I have topography, I have my retinoscopy, which you had just mentioned are useful tools, but may not be at the highest rank of the current detection technology. So what do I do in my clinic then if those are maybe the 2 things that I have? Well, then I suggest that what we need to do is something that I think, parallel to what Pentacam or other Scheinflug instruments do better, which in my mind, I think Pentacam does the best of the few models that I'm thinking, is that it's able to couple together risk factors that are usually related to keratoconus and combining, giving you more of a global view, and so that you're able to assess the risk factor profile of the patient better. So we need to aim to try to connect the symptoms and the signs and things that apart in addition to your topography. So something like your strong family history. And now I don't mean like any distant relative that you have a, I don't know, like second cousin many times removed or something like that having keratoconus. I mean, first degree, and maybe multiple family members in that first degree lineage that has keratoconus confirmed. And if you are diagnosing the only patient in his or her family with keratoconus for the very first time, then potentially encourage you to screen their family members because there may be a risk factor there that they are not aware of and that you would be the hero who would find them. So family history to me, I think is very important. Other type of mechanical breakdowns that potentially can affect the progression of keratoconus or weakening biomechanics of your cornea, such as any condition that can lead to eye rubbing, can be very important. As we talked about in the population-based epidemiology study, ethnicity and geography of where patients live can be important, such as those of Asian descent, Middle Eastern region seem to have higher incidence and of documented. So those are maybe things that, and people, now move around globally, so that maybe something that we want to pay attention to. Keratoconus and dry eye could actually be correlated. There's an ARVO poster by Dr. Amy Now and the authors that you see listed here in 2018, where they actually found the prevalence of NGD and patient with lid seal, meaning apposition of the lid is not congruent, is quite high, almost up to about 2/3 of the patients that they looked at. So maybe there's something there that we haven't noticed with keratoconus, and whether or not that is related to the floppy eyelid syndrome is unknown at this moment. But I know that they're still working on looking through their data, so something to look forward in the future. And again, continuing that theme of, well, let's try to do better at coupling the risk factors. If we don't have a computer software or detection technology that's going to do it for us, then maybe reviewing our medical charts become more important. So looking at the warning signs that, as we've discussed with the top 3, family history, eye rubbing due to any type of associated with other eye diseases, dry eye or atopic eye diseases or systemic associations, those kind of thing. But again, striving for potentially even earlier sign, going sort of even closer upstream to the root of the causes possibly of keratoconus, we need to also listen to more carefully to patients' subjective visual quality or visual complaint, because we know that early in keratoconus, a lot of patients don't necessarily lose their vision, right? But they start having some mild higher order aberration related symptom where they may start complaining about their vision maybe more at night, or that very vague loss of vision where sometimes they happen to have never had any history, but they could all of a sudden couldn't be corrected to 20/20, and they're at a new clinic and they all of a sudden get labeled as amblyopia or lazy eye, even though they never had that history before. I've seen a lot of patients like that with keratoconus. So certainly something to think about, that don't always try to correlate presence of keratoconus with loss of best corrected vision. So visual acuity, glare halo ghosting, maybe frequent changes in the glasses prescription or contact lens refits required, that doesn't make sense. Meaning it's not, our refractive history to maturation typically ends somewhere, mid-late teens, right? So if somebody's still having pretty significant changes in their refraction in their, say, mid-20s, that would make no sense, right? If there's no other systemic correlation, like, are they diabetic and their lenses or crystalline lenses are changing, even if they're in grad school, they shouldn't be, we always kind of talk about the quarter of a diopter per semester or per year. They shouldn't be significantly changing from that, right? So like, if nothing explains their refractive changes, even if they're being corrected every single time to 20/20 or 20/15, you should still be thinking, well, why are they changing? Because physiologically, that makes no sense for the eye. So those are the kind of things that we need to pay more attention to, because according to AOA, Academy of Ophthalmology, the preferred practice pattern is early intervention at earliest possible point when they're diagnosed with progressive keratoconus with cross-linking.
Clark, just a few quick points on that slide. I just wanted to mention a few little things that I've noticed also that I'm curious if you have also. Number one, with the eye rubbing, if you look at a group of keratoconic patients in allergy season, they all tend to rub their eyes with their palm of their hands or their fists instead of their fingers. That's one difference. Another thing that I've also noticed too is with delegating visual acuity to my staff, I miss hearing the way people talk about read the chart. And so EVOTZ2 or EVO, I don't get to hear that anymore. So I've actually had to train my staff to learn that difference and make me aware so I can recheck things. Because now with delegating certain things like visual acuity on a normal exam, that's something I might not hear. And then finally, the last point I want to make is the uncorrected vision or best corrected vision thing. We did a study at TLC about 10 years ago with patients who developed ectasia after LASIK. And one of the commonalities we found when we looked at their charts preoperatively is that they had a high incidence of up to 3 or more letters of difference between right and left eye. So the best corrected vision was asymmetric by 3 letters or more. And that was something that we weren't looking for prior to that study, and something we became a lot more sensitive to. So small losses in best corrected vision should make you look harder at these patients and search for keratoconus.
Yeah, I couldn't agree more with you, Bill. And I think especially that very last point highlights the fact that keratoconus is a lot of things. And first and foremost, there's a lot of asymmetry in its presentation, and including the asymmetry in the different lines that each eye would read or attain on the chart, as you just pointed to. And that small difference of half a line, 3 letters to that making a line of difference can be very important, even if somebody's 20/15 in one eye and 20/20 minus in the other. And so again, that's why we should get out of the notion that we think that keratoconus is somebody who's definitely 20/40 or worse, or 20/25 and worse before you start investigating. So I think that is very good points, and we're going to explore more about this asymmetry business within keratoconus as we go on towards the other part of the lecture. And so staying on the same publication, just because it gave us a lot of useful information to guide our clinical practices. In terms of, you may be thinking, okay, I think I'm getting the theme of how to pick up keratoconus, and we're going to talk more about different technology and how it can be implemented in clinic. But you use the word progression, right? You talk about progressive keratoconus and when to intervene. And so how would I, once I diagnose the patient, how would I then be able to monitor for progression? So according to, again, this same publication, progression would then at least include two of the following, which is progressive steepening of the anterior corneal surface. I think that we all know easily we can do that with topography, right? And then progressive steepening of posterior corneal surface. Now we're going beyond just the anterior surface, so now we're going to need a tomography like a Pentacam. And the third one, progressive thinning in the rate of distribution of the corneal thickness data from the thinnest point out to its periphery. And we're going to explain that point a little bit once we get later on, because there are visual illustrations that can, I think, explain better. But I believe the important thing here is, again, showing you which instrument can do what doesn't mean that one instrument, such as just the anterior corneal surface, that you could not use that to monitor keratoconus progression or diagnose keratoconus progression, but your threshold is going to be very high in between, in that you're going to wait until, if you're only using one single factor, your patients are going to progress under your nose without you knowing, before you are able to pick that up. And that's why a combination of at least two or all three of the factors that we talked about are going to be much more diagnostically powerful. And also the changes needs to be consistent over time, meaning maybe sometimes patients come in and the eyes are a little bit dry, they just took out their contact lenses, and that's going to have some influences to the way the topography is. And then some area may look a little steeper, some area may look a little flatter if you just remove the contact lens 5 minutes prior to measurement. So you need to make sure that that is a consistent change, hopefully small enough that you're not letting patient progress a whole lot before you decide to do something. But you also need to determine whether or not it's real data trend above that normal variability that every instrument may have. And that's why, again, looking at multiple risk factors that an instrument can collect can be very important. And also the very last point we talked about already, which is not to define this disease, at least not in its early stages, if that's our goal, to detect as early as possible, not to define the disease with with their acuity level, whether it's uncorrected or best corrected.
And Clark, also, I would like to add too that this does not, it excludes or does not include Kmax, and I think that's really important. I still see a lot of corneal specialists and a lot of surgeons out there relying upon Kmax. You want to comment a little bit about why Kmax was probably left out of this, and what the sensitivity of that metric is?
Right. And obviously, please fill in whatever I may not be quoting enough, but Kmax, although we can understand why it's a good metrics that a lot of clinicians and researchers are using, because it's a numerical value that's easy to use, right? And however, it only really points to a single point on the cornea, and that is the apex. And we already talked about the fact that a lot of times, I would probably say, if you only want to use a single point on the cornea as a metrics to diagnose, excuse me, or monitor keratoconus, Kmax would be better in my mind than, say, your central, pachymetry, for example, single data versus single point data. But the limitation is that it's a single point data, right? It's not giving you the morphology, the shape of the cone. You don't know where the base of the cone is, what that looks like, and the extent of the cornea. And patients may not always be looking at the same point in which you get angular decentration, which really throws off curvature maps, such as your topography. So for a lot of reasons, you can't really just Kmax or just flat K or just steep K. One single point data really does not do justice, but I suppose if I have to pick one, I would say I would at least want to have a Kmax if all that I could have is one single data point. What's your opinion on that, Bill?
I would agree, but I wouldn't want one point. I think what my experience with Kmax is it's very dependent upon fixation and alignment in any device that's measuring it. And the intertest reliability of the Kmax number, it's one of those numbers that if I test a patient 10 times the same eye with the same device, Kmax varies quite a bit, and that's just problematic in itself. So I would agree, probably there are other single metrics that may be intertest more reliable, but probably not as good in a clinical study, but I think they purposely left out Kmax from this definition of progression because these three parameters together are just much more sensitive and specific in defining progression. I think this is a significant leap forward, and I think you'll see a lot of the future studies adopting these parameters.
Great. So, you know, again, we're inching our way towards sensitive and more advanced technology, but let's not forget that a lot of our colleagues, we have to utilize what we have, right? Outside of referring and co-managing, maybe with other clinics that would have the instruments that you're looking for to order these imaging. What if you don't have that in your clinic? And so what do you do prior to, you know, purchasing a unit or getting a unit for your clinic? Well, you know, we all have some sort of pachymeter, some sort of keratometer in our clinic. So maybe looking at keratometry, and because our goal now is to diagnose as early as possible, you don't want to wait until you pick up somebody with whether flat K or steep K, especially steep K, because that's in my mind slightly more sensitive than flat K when we're looking at keratoconus. But you don't want to just wait until that's 50, 52 before you start saying, oh, that's probably keratoconus, because we want to detect earlier. And so I would say lowering it to 47 diopter or greater, and probably more sensitive if there's increases in keratometry. Again, that makes no sense because you know, our keratometry, the first few years of life, right? We should really, that maturation of the morphology of the cornea, diameter and shape becomes much more stable within that first decade. So you shouldn't really have very large changes or frequent changes in keratometry when you are, you know, of a certain age. So again, we need to be able to explain, and if it doesn't fall in within something that can be explained, then we need to start thinking, is cornea changing? So
and again, especially Clark in one eye only. I mean, again, when you see bilateral symmetrical changes, it's way less concerning than unilateral changes.
Of course, and especially if it's closer to 47. If you see bilateral changes jumping up to, say, 50 diopter, then again, that's very concerning, even though it's bilateral. So sure. Yeah, that's sort of how you would play with magnitude and location. But I think the idea is, again, less sensitive, so we need to couple the risk factors, and you need to have closer monitoring to be able to, for you to be able to establish a global trend. So you need to look at increases of different parameters, such as your cylinder, such as your myopia, because we know that more keratoconus patients manifest myopia, and also increase in your keratometry. You know, manual keratometer could actually possibly be useful if we didn't have to always just be imaging that central 3 millimeter in the center. And we'll come back to this idea of why that could be useful in a different format. But, you know, regardless, if we combine the history, the family history, the eye rubbing, and what we just talked about, you're starting to get better at picking up these keratoconus, maybe not the earliest stage. So what else can we do outside of looking at that greater than 47 diopter keratometry value increases? Well, and increases in different parameters. Well, if you have a topography that you could look at your, you know, tangential or axial map, now we start to at least be able to do some sort of curvature and shape analysis, and we could look for asymmetry, right? Not just asymmetry in vision that we talked about from Bill's research at TLC, but we could now actually look at your, say, IS ratio. Is there asymmetry on your inferior and superior curvature across the hemisphere line? And the way traditionally to do it is to pick a 6 millimeter diameter and look at the 90 degree, and typically 5 different axes, but at the very least look at the vertical line 90 degree, and at the 3 millimeter above, 3 millimeter below, and subtract the difference is your IS ratio. So when it's greater than 1.8, 2.0, that gets to the point where it's very unlikely that is a variation of normal. So again, you're still looking at, if you're still unsure, if you have a little bit of mild asymmetry that you're picking up, and you know, spidey sense is up, then again, you want to keep the patient close and watch them. Not every year, but depending on the risk factor, maybe every 3 to 6 months. And therefore, you could look for consistent increases because we're relying on something metrics that are less sensitive and specific for keratoconus. So coming to then using a Scheimpflug imaging instrument, which I pride myself in using it every day in my clinical practice, but I know Bill's the true expert here. So Bill, you want to jump in on this one?
Sure. Presently, the state of art of keratoconus detection is using a Scheimpflug device such as a Pentacam. There are other devices out there. So the numbers you see on the slide are unique only to Pentacam, so they can't be used for other instruments such as a Zemer or Orb scan. But what we're looking at in these classic 4 maps are front elevation, back elevation, pachymetry or corneal thickness maps, and a sagittal axial map. And what we typically see in keratoconus is an elevated point above a best fit sphere that's greater on the back than the front of the eye. As we know, most cases of keratoconus begin in the back and eventually will make their way to the front of the cornea. And we have elevation values that are normative values, and devices like the Pentacam have these built in, so you don't have to memorize these numbers. And they also have separate databases for both myopia and hyperopia. We know that anatomically, hyperopes are different than myopes. So particularly the posterior elevation normative data is significantly different. You see here 18 as abnormal for myopes, but up to 28 microns of elevation could be abnormal for hyperopia. So it's important to know what kind of patient we're dealing with to put them in the right database, normative database. Also, it's very important to look at the pachymetric progression. That's why these corneal thickness maps of the full cornea are so crucial. In fact, a lot of people and a lot of papers suggest that the pachymetric distribution is actually the most sensitive single factor in early diagnosis of keratoconus. It's also important, again, I can't emphasize how important it is to keep in mind of the asymmetry of the disease. One of the few things that the Pentacam can't do automatically on its own is tell you the difference between the thinnest point of the right and left eye. That's a manual number you have to subtract yourself. And we know 17 microns is suspicious and 25 microns is abnormal. So it's one of the things that I always do is I take the maps on the right and left eye and always subtract the thinnest points and look to see, is there a true asymmetry there? Is there decentration of the thinnest point of 0.8 millimeters or more? Or any disparity between, as Clark described with the topography, any disparity in the elevation from superior to inferior. So again, looking at all these factors and using the normative databases on the Pentacam is really helpful in trying to decide if your patient is abnormal or not.
Yeah, that's great. And Bill, like I said in the sort of very last sentence here, these are, again, more asymmetries for us to look at, right? But I personally, looking at all these factors, I value more, or at least put more weight on the pachymetry distribution, and I'll show you an illustration of what that is, and also changes over time. Meaning, if somebody's like posterior elevation of a myopic patient is 20, and everything else, I can't really seem to find any other clue that makes me think it's frankly keratoconus right away, meaning axial map is fine. There's not, corneal thickness doesn't seem to be differ that much in both eyes, and the apex centration doesn't differ, and it's 525, 530 thickness. That doesn't seem like it's anything that's would make me think it's outside of the 2 standard deviation. All that together, I pay more attention to pachymetric distribution and changes over time. So somebody's 18 and 3 months later, this person is 20 elevation of a myopic patient, or 21. I am more concerned as somebody, obviously, I've seen this patient maybe for a couple of years and always stays at 18 or 19. So changes over time to me, obviously, to me is even more important, especially when you have really early or mild borderline findings. Something else, and we'll come back to this point, but something else that can be important, we all know, or can sometimes break the tie for me if everything seems very borderline, is maybe I'll flip over to look at aberrometry. Many people don't, because we call it a Scheimpflug or tomography, or sometimes even topography interchangeably. I think many people may not even think of to look at the pyramid structure of the Zernike's and look at the anterior or you could even actually separate anterior and the cornea versus entire eye using Pentacam. But that can be important when we look at their vertical coma. As we know, most keratoconus patients struggle more. That's one hallmark of keratoconus patients. That said, looking at their vertical coma and the coefficient. And Bill, you actually also looked at a lot of data from our refractive surgical care days, where you have found that vertical coma greater than 0.3 micron in the coefficient can sometimes be your tiebreaker to say if somebody is suspicious for keratoconus. Do you want to tell us a little more about that?
Sure. In the similar study we did of 160 patients that went ectatic, compared to a normative cohort of patients who 8 years after surgery did not go ectatic, we saw that preoperative values of coma of 0.3 or more was a statistically significant factor for the risk of developing post-LASIK ectasia. So it is a variable that we look at very closely, especially when there's asymmetry in coma between the right and left eye. Again, asymmetry keeps coming up. But again, it's an important factor. While it's somewhat sensitive, it's not always specific. So there's other things that can cause coma besides keratoconus, but it is something that, again, we look at very carefully when you're screening an eye for an elective procedure like LASIK surgery.
And so while here we're showing you somebody who's borderline suspicious with a coefficient value of -0.358, and again, many different, obviously there are other diseases that can give you HOA and vertical coma. So this is maybe sensitive but not specific, as Bill pointed to. And here's somebody who's much more of a definitive keratoconus. You can see that coefficient value really jumps up, really increases. And obviously, again, this is, like I said, I personally only use this if I really couldn't decide from everything else that we've talked about and are going to talk about, but it's something that I thought would be nice to kind of pay attention to. So one thing that we were, when we were talking about the use of pachymetry and elevation versus curvature, is the idea that, you know, regardless of whether we're using curvature-derived data, such as looking at your topography or axial map or tangential map, versus if you're looking at elevation-derived data, such as looking at your posterior elevation, interior elevation in the 4 maps that Bill had told you, there's one thing in common, and that is the output that we're seeing, such as the map here with a central sort of island appearance in that elevation map. It still requires a line of reference, and we call that best fit sphere, or BFS, right? So the difference you see, if this were a keratoconic cornea being shown as a triangle, the tip of the triangle is the apex. The difference between the apex and the rounded line of your best BSF line, that difference is the 30 micron that you're seeing in that map output as the maximum elevation. So the greater the difference, the reason I'm explaining that is because the greater the difference of that distance between the apex of the triangle and the rounded reference line of BSF, the hotter that spot becomes, or, you know, the warmer and the more color series is shows up in both the elevation and the curvature. So it'll be great if we can figure out a way to lower that best fit sphere, lower the line, so we increase the distance between the rounded BSF line and the tip of the triangle where the apex is. Then that would help us be able to detect earlier of somebody, because then the difference is exaggerated, right? What's normal versus what is really elevated. So how do you do that? Well, you know, if we look at the Pentacam output here, and if you look at this interior elevation map, whether it's anterior or posterior in this, you know, in this scenario, it doesn't matter right now. But if you look at that and say, okay, how can I make that, you know, plus 72 elevation even higher, or so that I could detect it sooner if I could lower that BSF. So knowing that the apex itself, because that's where all the highly elevated numbers are coming from, it's going to artificially actually do the opposite. It's going to make that rounded BSF line that I showed you closer to the apex, right? Mathematically, because you're averaging a higher number, a steeper number of BSF. So if you actually remove, we wipe out the that we purposely ignore the area that has the highest value of elevation surrounding the thinnest point. And it's important to use the thinnest point as your center because that typically is very reproducible and correlates quite well with keratoconus apex if we're looking at for keratoconus disease. Okay, and so if we kind of overlook that central 3-4 millimeter, you artificially make that BSF line calculation a flatter curve, and therefore you're exaggerating the difference between that distance from the BSF curve to the peak of that triangle that I just showed you. So that's the idea of this extra display called BAD on the Pentacam, where we're basically filtering out that central area 3 to 4 millimeters surrounding the thinnest point so that you could have a flatter curve with a BSF line. And so you could catch milder earlier keratoconus better. And there are so many actually data that you could look at on this BAD display, but the two columns on the left-hand side that you see elevation front 3 map, elevation back 3 map. The first map is the typical output, the typical axial map that you would see in the 4-tile format that Bill first described. The second one in the middle are what we call enhanced surface, meaning we've removed that central area that artificially steepens up the BSF. So we remove that, therefore you're enhancing the difference between the apex, the distance between the apex, and now the much flatter BSF line. And then the subtraction map to give you another indication in case a middle map doesn't already alert you into, hey, something's not right. A normal cornea shouldn't have that increased warm color by that much if keratoconus isn't, or something abnormal isn't present. And therefore the subtraction map is something, if there's too much of a difference between the middle enhanced map and the top sort of typical axial map, then you'll see hot spots showing you that there's a greater difference after the enhancing software, and that then something is suspicious may be going on. So that's a really good tool usually that I like to look at if I haven't diagnosed the patient with a condition yet, because once you diagnose the patient, you don't really need this diagnostic tool, or at least it's not as useful in my mind. But the other thing that I want to look at before we move on to the next slide is those bottom. So again, doesn't matter if you look at the top BAD map or the bottom BAD map. Actually, I like the bottom one. I like to look at the bottom one better in this scenario. So you look at the bottom one, and if you look at those two white rectangles, you could see it says CTSP or PTI graph. And if you look at those, that's your pachymetry, the pachymetric distribution that we're talking about. So it's showing you the rate of flattening of the cornea when you go from the thinnest point, which is your 0, on the vertical axis, it's your 0 line, how it thickens as it goes towards the periphery. Why is that important? If you think about it, if you have keratoconus, if you have your apex is thinner than, let's say your apex theoretically, if you have really severe keratoconus or moderate keratoconus, your apex is a lot thinner than your normal population. So therefore, and yet most keratoconus, we know your peripheral cornea is near normal, meaning it's not as affected, right? We could argue whether it is or it is not, but it's near normal, let me call it that way. And so the rate of thickening is a lot greater compared to somebody with normal cornea. So if the rate of thickening is a lot greater in the periphery, such as you see in that bottom graph, you can see that red line way exceeds the 3 black dotted lines showing you the ±2 standard deviation from the center of norm. You can see that it thickens a lot. That red line is a lot lower because the lower it is, the thicker the corneal thickness or the percentage of thickening is. So that means that somewhere within that range, or more paracentral to it, to that peripheral point. There must be some sort of thinning somewhere in order to give you that much thickening in the periphery that is unexpected. So that is the reason why I think that pachymetry distribution is very useful, not just relying on one single point. Why is that important? Because I've had patients who are 540, 550 in the thinnest point, and they have keratoconus. Right, so you can't really look at like, oh, 480 is or 470 is keratoconic and 530 isn't. Well, that's not true. I've seen plenty of patients, who are really early and having, very sufficient corneal thickness in the center, and therefore looking at that relationship of thickening towards the periphery is much more useful. Do you have anything that you want to add, Bill?
Just quickly, I like to add that it's important to understand that this BAD analysis was designed to detect abnormal corneas, not necessarily keratoconic corneas, even though when we screen patients, the majority of the patients that we find are keratoconic. But real power of this is the final D number, which is what Clark is circling. This final D number is the result of a regression analysis of 9 sub-D values, 5 of which are shown on the printout, 4 of which are not even revealed. But how this works is it takes these 9 values, weights them all differently, and then performs a regression analysis. And that final D value is the most sensitive and specific, with about 94 to 95% sensitivity and specificity of determining whether this eye is normal or abnormal. So it's really the value. It takes the individual's interpretation and experiences out of the mix, using the computer regression analysis to determine whether your eye is normal or abnormal. So I think that's the most powerful feature of this particular display.
Yeah, no, that's a great point. Like I said, there's so many different vectors that we could look at on this page, but I've got to move on because I could stay here for like another 20 minutes. And so there are RMAX and there are other things that we could look at. I do want to, if you do have a Pentacam in your clinic or just received one, make sure that in this display that you are selecting the correct refractive group, because we talked about the fact that you could have different physiological characteristics if you're myopia versus hyperopia and mixed astigmatism. So you could see that I'm hovering over the circles that you can have your technician select pending patient's incoming refractive error. So that's also very important there. Let's go to the next slide. So again, so I diagnosed the patient, and you said once I diagnose the patient, and that BAD page that you just went through may not be as useful in terms of other uses. So how do I then monitor for progression of patients? Well, let's go back to the reference map that I showed you before in terms of how we selectively remove some of the data from the central 3-4 millimeter surrounding the thinnest point, because that is very useful doing that. We talked about exaggerating the difference between the peak of your BSF line curve and compared to the apex of that triangle. So now what if we bring that back? Because if I were to ask you, where do you think, because we talked about the fact that peripheral cornea is near normal for quote unquote for keratoconus. So there's no point in watching area that's almost normal or normal. How are we gonna be able to better, more effectively watch for progression of a keratoconus area or keratoconus cornea? Well, looking at around the apical area, that's the area that is weaker relatively, and that's the area that's most likely to progress, if you would. And therefore, let's go back and actually, what if we only focus on the areas, that 3-4 millimeter area surrounding the thinnest point, which should again, represent the apex of the cone much better. So if we do that, that would actually give us a more sensitive way of being able to monitor the patient. So therefore, you could actually get into a whole new different display on Pentacam. But I want to focus on this new A, B, C, D. A stands for your anterior curvature, B, your back or posterior curvature, C stands for your corneal thickness or your thinnest pachymetry area, and D, not as often used, but I encourage that we should, if we could document it in the, not just in the chart but also in Pentacam, the best corrected distance visual acuity. And this is because for so long we've been looking at your Amsler Krumage staging that characterize keratoconus patient with refractive error. Like if it's greater than 8 diopter myopia or less, if it's greater than 5 diopter cylinder, and then if the pachymetry is less, it's great at that time. That's the best that we have, but it really isn't as representative, you think about it, for keratoconus patients, and certainly not as useful to kind of diagnose progression. So this ABCD for me is a better way of describing keratoconus, both morphologically and functionally, because we're entering in vision, if you could. And then Pentacam takes it even one. I feel like multiple steps ahead, where it gives you it categorizes or color codes different scan dates. Because remember, I said it's important, depending on risk factor of the patient, that you want to monitor them. But when they come back, what are you comparing, right? Bill already said, well, maybe Kmax isn't the only thing, and probably he doesn't even want to rely on that. So if we look at the, your anterior curvature, your posterior curvature, your thinnest point of location, to see if it's further thinning out and is visual acuity changing, and looking at the color display makes it very easy across different time points to say, is it consistently, because remember we said consistent increase, that global view of what's changing is very important. So if you look at then the different color scan, you can see the longer the bar graph, the higher the staging, the severity is. And so it gives me a very easy visual analog, if you would, to compare changes in the patient. And also, I think it also gives me, sorry, is that you, Bill?
Yes, that's me, sorry.
Oh, no problem. I thought you wanted to jump in. So stop me anytime you want to jump in. So it also gives me different intervals of staging, right? Like you could see on the top, and it'll give me different scales. So here I'm only showing a scale up to about like 2.5. As you can see, the vertical line says 1.6, 1.7, 1.8 here, and then here is 2.5 per different per category of A, B, C, or D. And I can change my baseline exam as well, from which the subsequent exams compares against, and we'll talk about why that's important. And I think it also shows me they've gone through population studies to come up with the software to say, is a normal cornea probably closer to somebody who, say, subclinical keratoconus, or maybe undergoing refractive surgery? Is there some sort of inherent risk, but maybe not quite meeting the statistical significance level of a keratoconus patient? Those are the green flags. And then you have the red flags, where the solid one is 95% confidence interval that if this were a keratoconus patient, something is changing significantly, because that sort of noise level has been met, right? Remember, we talked about the fact that that variability has to be consistently over the noise level of your machine, the variance that your software can handle. And so that's very important for me to not just look at the bar and the change, but whether or not statistically it makes a sense for me to say something is changing. And that's why I think that ABCD is very important. And again, you could align each one against the baseline, and you can even change the scale to, like I showed you that in the previous scan, that everything kind of stops at about 2.5, 2.5 scale, which it gives me, it kind of maximizes the distance of the separation between each color bar. But what if I have something that is, you could also flip over to a full scale, so all the 4 stages show, it shrinks the biracial, right? It shrinks the color bar, but it allows me maybe more of a global view of something. Maybe one parameter is particularly worse, or you have many different visits to compare. So I think that's when, to me, full scale can be more important to look at. It's sort of like your universal versus absolute, on your topography, sort of similar principle there, if you would. And then you could even choose to magnify it if you really want to see the separation very well in between each color bar, if they were really close together. But like I said, I feel like if I utilize that statistical confidence interval flags, or they call it gates, a little more often than needing to kind of more magnification. At least that's me. And then the reason that I say it's very important to then be able to select my baseline that I want everything subsequent exam to compare against to is because you may have different treatments, right? And probably cross-linking for progressive keratoconus is going to be really your most common treatment recommendation. We'll talk about this a little bit in our part 2 in the future, but there's a small chance, right, that some patients may continue to progress, or maybe they may do that X number of years down the road. So how to make it easier for yourself to catch that, to be able to properly monitor your patient? So if you actually select a date where where cross-linking treatment was done, then these blue confidence interval or blue gates then appears, because then it would be able to help me better to do post-operative or post-cross-linking monitoring to see if something is changing, not due to the fact that the cornea is steep, meaning more severe keratoconus, you're going to have a little bit more variance from visit to visit, right? So it's not because of noise level due to the disease severity, but it's actually truly statistically significant changes that I'm witnessing after cross-linking. So I think that is, to me, very important. And I know that we're going a little bit long here. Is it okay, Bill, if we keep going for a little bit, or should we give everybody a break from my annoying voice?
You're not an annoying voice at all. I think there's just a lot of information here. I think, Clark, just in the interest of time, why don't we, I think this is a good point to stop, because now we're going into future considerations. And I think we can start off on part 2 with this next time. So why don't we take a break and see if there are any questions?
Of course.
Let's see if I can pull that up. I'm having some computer problems, but.
And if anybody wants to enter a question.
Michelle, can you pose some questions for us?
Yeah, I'd be more than happy to pose some questions. Okay, I just wanted to say thank you for that great presentation, both of you. And if you do have any questions, please feel free to enter those questions in now, and we'll see if we have time to get to them. If not, I know that we can ask those questions in the next session as well. All right, I do have one question that was talking about color bar scale settings, and how important is that to be careful about color bar scales and incrementation of colors when I'm reviewing my maps, let's say my 4 maps refractive, and monitoring patients for those islands of elevation.
So the good news is that the BAD report, all the color scales are fixed. You can't change those because that's part of the normative database. But on the 4 map refractive, color scales can matter. And I think it depends on what you're using the 4 map refractives for. If you're using it for fitting contact lenses, or you're using it for screening for keratoconus. I think that I usually use a half diopter scale. I think the colors are less important. I like to use maximum colors scheme just to see the subtle details. But I think if you're used to one color scheme versus another, I know that most ORB scan users like the American color scheme better. Most Pentacam users like the Belin intuitive color scheme better. So, Clark, do you want to comment at all on your cutoffs and how you set up your device?
Sure. I mean, I love the fact that we could change our color scheme and even the steps between the dioptric units. And I think that may be what the question is coming from. But I personally like the Belin's intuitive color scheme better. I think those who are more used to, I think, looking at, say, ORB scan and now have upgraded to a Pentacam, they may like the sort of American color scale or scheme better, because that, to me, displays itself a little closer to what the reports look like from ORB scan. So that may be the reason why. But I personally like to, most of you probably know that if you just kind of right click on the color bar here in each map, you could change the display unit. And so you could choose the color scheme output. You could also change from like a very sensitive color display where every quarter of a dioptric step is a color change. That can make your map look sometimes overwhelming. I typically like to use half a diopter. You could make it less sensitive to make it a 1 unit diopter step. I usually prefer half a diopter. And to be honest, because of the ability of using BADs, the map display that's fixed, I'm more used by 4 map now to just kind of clue me into, is there anything that seems abnormal before I look, so that it clues me in to look at the BAD display in terms of, in case my technician didn't print it out for me yet, I would go, go to the computer and look it up on my own. And so that's sort of how that's how I use the format display now. So therefore, I feel like the color display and the unit of changes in each pachymetry map or the elevation or the curvature map does not matter as much to me now.
Yeah, I would add too that because the tomographies are not tear film dependent like Placido, with Placido I was weary of going to a half Doppler or more sensitive step because of the noise from the tear film. But with Pentacam, you don't get that noise from the tear film, so I feel very comfortable going to that half Doppler scale.
Agreed.
Thank you for that. Great answer. Our next question is, do you have different reference numbers for different age groups of patients for the D value?
That's a great question, and I think most surgeons who utilize the BAD map for screening patients for refractive surgery will develop different cutoff numbers, but based on two factors. One is the patient age, as it's a question asked, but also based also on their risk tolerance. Some surgeons are more aggressive than others. Some